Good afternoon and welcome to a panel discussion on faith and humanitarian action, sponsored by the Center for Humanitarian Health. My name is Cortland Robinson and I'm Associate Professor in the Health Systems Program, Department of International Health and core faculty with the Center for Humanitarian Health, which is, as I noted, hosting this event. Actually, we're part of a seminar, so those of you who are in the class, part of this, this is a seminar in humanitarian health that I co-teach with Dr. Paul Spiegel, who is director of the Center for Humanitarian Health and professor of the practice in the Department of International Health. So those of you who are not part of the class, there's no quiz. We won't have any special reading assignments, although some of you did have some reading assignments for this long-awaited session. We've had multiple efforts to get this going. Snow and various other scheduling problems delayed us, but third time is a charm, we hope and believe. So off we go. But before I offer some opening remarks and introduce our four panelists, just a couple of housekeeping notes. One is that the event is being video recorded and webcast, so best behavior. But also just to let you know that if you have a question, we will have time for Q&A at the end. Please go to one of the stand microphones or we'll have somebody to hand the microphone around. You don't need to introduce yourself if you don't wish, but please do if you have a comment or question directed at somebody, please just make note of that. But hopefully there'll be time allowed to carry that forward at the end of these presentations. I also hope it's fair to say that we need to recognize that sometimes discussion of religious beliefs can be a sensitive topic, that they can reveal sometimes strong feelings and emotional responses. And I hope it's fair to say that nobody is here to promote the views of one faith over another or criticize any unduly, but rather to seek honest and open dialogue. All beliefs are respected at this table, including a system that may have only skepticism or disbelief. So to begin, when I was a young child, raised in a Christian and church-going family, I learned to love hymns even before I understood what they meant. And there was a beautiful African-American spiritual that had these lines: "There is a balm in Gilead to make the wounded whole. There is a balm in Gilead to heal the sin-sick soul." While I loved the melody and I felt meaning somewhere deep in my bones, I wondered, where in the world is Gilead? And how can a balm heal anyone? I thought they blew people up. Just to spell this out, I did not know that the balm being referred to was B-A-L-M, a healing ointment, and not B-O-M-B, an explosive ordinance. And while I'm clear on that difference now, and I know where Gilead is, I still hear echoes of both of those words in that song, as I think faith itself can be rooted in the chaos and destruction of human experience, as well as in the search for healing and redemption. So let's state this outright. Faith, particularly in its most extreme and intolerant forms, can be a force for destruction, a weapon, a bomb hurled at the unbeliever, the heretic, or the rival religionist. In the context of humanitarian action, it is religious conflict itself, fueled by geopolitical, economic, and ethnic tensions and rivalries, that may spur the very crises that the humanitarian community, including faith-based organizations and people of faith, seek to heal. But faith, of course, can be a goad for action of a different sort. Action that seeks physical and mental healing and restorative justice, and dare we say it, peace, shalom, salam. Here too we must ask, what is the role and function of faith and faith-based organizations and initiatives in humanitarian response? How do we reconcile faith and science, faith with best practice and core humanitarian values? Where is the common ground, and how do we build and expand it? How can faith communities and faith-based organizations help to build trust where trust itself may be particularly lacking? The Ebola example, which we'll talk about, comes to mind. And even a good faith effort intended to relieve suffering and to heal, to offer BALM, balm, may be construed as divisive and threatening. So our conversation today is about faith and humanitarian action, recognizing that faith can incite confrontation, generate confusion, and also inspire collaboration and connection. And we're joined today by 4 people who bring humanitarian expertise and also a faith perspective, which I've asked them to share. While there are many religions in the world and many more that could have a seat at this table, we have focused today on 3, Judaism, Islam, and Christianity. Which brings us back in a way to Gilead, or Gilad, in Hebrew or Arabic. I'm not sure I'm pronouncing that right, but these are cognates, located in what is now Jordan. And I have it on a reasonably reliable source, well, Wikipedia, so there's that Gilead may mean hill of testimony, but an alternative interpretation is that it means rocky region. So whether we stumble upon rocks in the wilderness or ascend to a hilltop moment of shining witness and testimony, or maybe do some of both, we invite you now into this discussion. So, our first speaker, I'll present all together, and then each one of them will come up and speak individually here at the podium. Samantha, or Sam Walthus, is Director of Humanitarian Response and International Operations at the American Jewish World Service, the leading international Jewish development human rights organization, supporting more than 450 grantee organizations in 13 developing countries to advance human rights of women and girls, LGBT people, indigenous communities, ethnic minorities, and advocates for freedom and democracy. She previously served as Director of International Service at AJWS, overseeing voluntary programs to help build capacity among partners worldwide. Prior to that, she worked with Princeton in Asia, Family and Children's Services in Tulsa, Oklahoma, has a master's in international studies from Oklahoma State University, and a BA from Colby Sawyer, and is a native of Belgium and speaks fluent French. Maybe actually, if I might, let's reverse the presentation, ask you to talk, and then we'll introduce each of you in order. Maybe we'll do it that way, if you don't mind. Sam Walthus.
I've already messed it up. Sorry. Great. Special thanks to Court for having AJWS speak today, and also huge thanks for your patience with scheduling. In the middle of between the blizzard and the reschedule, there was a massive cyclone in Mozambique that many of you probably have heard about, and the joys of humanitarian responses that you never really know where you're going to be and what you're going to be doing at any given time. So huge thanks, Court, for your patience. As Court said, I am Sam Walthus. I work for AJWS. I oversee humanitarian response and international operations. I've been there for over 12 years. I've also, prior to moving to the New Jersey, New York area, I was in the Peace Corps in Central Asia, also worked in Oklahoma, lived in Singapore and Saudi Arabia, and of course, Brussels, where I'm from. So it's a little bit of background. A little bit about AJWS. Have any of you ever heard of AJWS? We'll start there. Great. So I may call on you to talk about it as well. So we were founded in 1985. A Jewish businessman and a Jewish international aid worker recognized the need for a North American Jewish organization that would respond to issues outside of Israel or North America. And they were inspired by the Catholic Charities of the world or the Islamic Reliefs and said, we need the same thing for the Jews. So they partnered with Elie Wiesel. They founded AJWS. And really, they recognized it as an organization to support local people themselves to create the change they wanted to see in the world. They were inspired by the Jewish obligation to repair the world, or what we call tikkun olam. At its root, AJWS holds the basic tenet from Genesis that everyone is created in the divine image of God, or what we call B'Tselem Elohim. All of us are imbued with this divine spark. We're all worthy of dignity and respect. We're fundamentally equal to each other, and each person has fundamental rights which guarantee a life of liberty and dignity. Our founding was also deeply rooted in the Jewish history and experience that you all know about, from the Exodus through the Holocaust, which really has sensitized Jews to the experience of those who are oppressed or marginalized all over the world. So Jews know what it's like to be denied citizenship, to be persecuted for who they are and what they believe, and it's that history and sensitivity that are really underpinning the values of the organization today. Though many may not have recognized it at the time, the founders of AJWS were part of a movement in the 80s where Jews took the activist political energy of the 60s and 70s and channeled it into a set of Jewish organizations that were formed to really work on universal causes like environmentalism, racial and economic justice, and of course, equality and international development. AJWS has a fairly prominent role in American Jewish life. We are the leading American Jewish organization positioned to respond to global trends of authoritarianism, gender-based oppression, and of course, global climate change from the grassroots on up. In some sense, we're really the American Jews organizational gateway to the developing world. We also provide an opportunity for North American Jews to direct their tzedakah to addressing root causes of poverty and oppression and injustice across the globe. We have deep relationships with social movements and social change organizations in 19 countries around the world through our grantee partners, and we're seen as kind of a leading American Jewish organization for global analysis and leadership. Our mission is that we are inspired by the Jewish commitment to justice to work to realize the human rights and end poverty in the developing world. We are a human rights philanthropist organization based in Manhattan, but again with a presence in 19 countries around the world. Here they are. We work in Asia and Latin America and the Caribbean, parts of Africa. We have staff and consultants in these 19 countries. And we really have two programmatic pillars. One is through our grant making and accompaniment of our partners, as well as through our advocacy work, both in DC as well as internationally through the UN and other mechanisms. There are 4 different issue areas that we work on. Briefly, SHR, or sexual health and rights, where we work on the health rights of women, the LGBT community, adolescent girls. Our flagship program in this area is Ending Child Marriage in India. We also work on LWCJ, land, water, and climate justice, particularly with indigenous communities who are fighting for their rights to their land and to their water. CPR, or civil and political rights, where we're working to build and strengthen democracy in countries. We work on peace building and strengthening the role of women and youth in particular in political movements. Last but not least, my baby, humanitarian response, where we utilize a human rights approach to support local communities themselves to respond to crises that they're facing. So in terms of our approach, we are firmly rooted in using a grassroots approach. What does that mean? It means that AJWS invests in organizations who understand the problems in their own communities and are best equipped to realize their own visions for justice. This is incredibly important. We support them towards their own visions of justice. So what does that mean as it relates to really the faith aspect of this conversation? Because of this approach, we often are supporting religious and faith-based groups who are both marginalized themselves or oppressed in their own communities, but are also leaders in their communities and who are trusted by their own communities to implement the change that they want to see happen, especially in times of crisis in the context that we work in. So a concrete example of how we do this. It's interesting. We've talked about the Ebola example on multiple occasions, but it is very a key aspect of how we did this at AJWS. AJWS has been working in Liberia for over a decade. So when the Ebola crisis hit, our partners came to us and they said, listen, we need support to address the need for the fear and misinformation about Ebola. The LGBT community that we're working with is really being blamed for the spread of Ebola. We need you to help us to quell the panic and to teach people about how to protect themselves. So these local activist groups, because they are local from their own communities, we're best positioned to take this work on, especially one particular group, and it was called Nicole, that we partnered with. This is the National Imam Council of Liberia. And we partnered with them because they had the trust of their communities. When the INGOs were coming in and the other aid organizations were coming in and the communities were saying, we don't know you, we don't know why you're taking our community members away and we're not seeing them again. The only people we trust are the local imam in my community. So we helped the local imams spread the message of safe burial practices. They spoke to their congregants and helped give psychosocial support that was much needed in a time of severe crisis. They also conducted safe burial trainings. They did Ebola surveillance within their own communities and really identified those households that were most vulnerable to this virus. Finally, as a faith-based organization and leader in the Muslim community of Liberia, Nicole was able to ensure that Muslim burial practices, often associated with Ebola transmission, were addressed in a culturally and religiously sensitive manner. Another piece here. This is, I spent a whole lot of time in Cox's Bazar, Bangladesh, where there is a massive Rohingya crisis. Many of you know, April 25th, a couple of years ago, over 700,000 Rohingya refugees fled Burma and descended upon Cox's Bazar, where they are sitting under tarps in horribly crowded, difficult conditions. Yet again, the imam's role is incredibly important. They are seen as a trusted community member in many instances, and they actually have been built into the humanitarian architecture in Cox's Bazar as a key person for the aid organizations to consult with and to help distribute supplies to households. With that said, in addition to that, AJWS is actually one of the only groups that are supporting Rohingya-led organizations. Quite frankly, they're not even actually allowed to operate. They operate under the radar so that the Bangladeshi authorities don't know that they're operating, and AJWS is supporting them to help their own communities in the camps. Why are we supporting them? Because these are the people that are trusted by the communities. A concrete example is a group that we're supporting who has formed a group of community health volunteers, primarily women, who go from house to house to talk to women and adolescent girls about their own reproductive health, as well as safe hygiene practices for them and their children. And the reason why it's been so successful and also incredibly important is because some of these households have pretty fundamentalist beliefs, and these women can't leave their own homes to access the basic services that the NGOs and INGOs are there to provide. So to have these women that are from their community go to them and say, here are some services, here's how to access reproductive health, here's what I can do for you, has been incredibly important. Additionally, and this shouldn't be minimized, is that it's also helping build the leadership capacity of a population that has been marginalized, quite frankly, for generations. We at AJWS also understand that faith communities can be powerful advocates. In this example, I'm speaking to the North American Jewish community's power with the US Congress, for example. We recognize this and formed what we call the Jewish Rohingya Justice Network. It's a powerful consortium of over 19 Jewish organizations representing all four major branches of Judaism. And these groups, led by AJWS, are working to pressure Congress to pass the upcoming Burma Human Rights and Freedom Act of 2019, as well as to deepen awareness on behalf of the community of the crisis that's happening in Burma and Bangladesh. It's incredibly powerful when there's a group of 30 to 50 rabbis descending upon Capitol Hill to advocate on behalf of the Rohingya Muslim community in Bangladesh and also in Burma. So we see the faith community as also an incredibly powerful advocate in some contexts. We also know that interfaith partnerships are powerful in crisis contexts. In this case, it's Tarit, South Sudan, where all of you probably know there's a civil war that's been going on. AGWS is responding, and we recognize the importance and prominence of the Catholic diocese in this particular community. We're partnering with them to do peace and conflict reconciliation, to do human rights education, and gender-based violence reduction with their own community members. And lastly, in addition to being powerful allies and really agents of change in times of crises, we also know that religious minorities are often excluded. In this example, another place where I spend considerable amount of time is Nepal. Since the 2015 earthquakes that killed over 9,000 people, we partner with monks and nuns who are Tibetan Buddhists and who are incredibly marginalized in a place like Nepal. This particular group lives on the Nepal-Tibet border, and 206 of their homes were completely collapsed after the earthquake. So AGWS partnered with them for them to help build their own homes and also their own meditation centers. In this picture, it's the nuns, not the monks, but we've partnered with both. So in short, we know that religion and faith plays a very prominent role in times of crises, and that faith-based communities are both marginalized and often excluded, and AGWS helps support them in those contexts, and also can be incredibly powerful allies. We also know that religious leaders are trusted often in these contexts by their own communities, so that when the humanitarian aid organization comes in and the community is wary of them, they act as a very important conduit and liaison between these Western organizations and their own communities, since they already have the trust built. So thank you. If you have any questions, I look forward to hearing from you guys.
Thank you, Sam. We'll save questions till the end. Thanks, Makiba. So our next speaker is Osama Zakut, and he is specialized in humanitarian response in a number of different contexts, demonstrated history of working in emergency disaster contexts in Palestine, Syria, Jordan, Libya with the International Committee of the Red Cross and the International Rescue Committee. And he served in a number of managerial and technical positions with the Palestinian Ministry of Health prior to joining SAMS, the Syrian American Medical Society, a group that we know very well and collaborate with quite extensively. He currently leads the Global and Emergency Response Unit at the headquarters in Washington, D.C., and his portfolio covers a wide range of countries. Recently, he was tasked to lead the development of a SAMS health information system in collaboration with the Hikma Health Group, Harvard University, MIT, and our very own Center for Humanitarian Health. And he has an MPH in global health from Harvard University. Osama.
Thank you very much. Thank you, Kurt. Thank you, Mohammed, for this kind invitation. And I just wanted to start by saying that I'm not representing here SAMS. I'm not talking on behalf of SAMS. I'm talking on behalf of my 14 years of experience in humanitarian context. We know all that SAMS is not a faith-based organization, so this is why I wanted to emphasize this before we start. When I was invited to this interesting talk and very, very important talk, I think in humanitarian context, I was thinking what I would go and say about. Faith in humanitarian action is, there are many dimensions that we have to keep in mind. Is it like the dimension where me as a practitioner, as a Muslim, work in a humanitarian field, how Islam and being a Muslim is motivating me to do humanitarian work? Or is it related to the type of crises that we are responding to, if it's driven by faith or religion? Or there are many dimensions that we can talk about. I can summarize these dimensions by the practitioners. When it comes for me, as Osama working in a humanitarian context, I find that Islam is the main motivator for me to work in a humanitarian field. Because when I look back to some of the comments that leaders of Muslim scholars have been saying, like, if religion lose you your humanity, this is extremism. or I would call it like King Abdullah of Jordan has said, al-Khawarij. So I really I think that like what we call it here, extremism or moderate. I think Islam, there is no like extremist or Muslim moderate. Islam is very clear, very clear for many Muslims. Like over 95% of the Muslims are, if we call them as they are perceived in the Western countries, they will be moderates, and very few who are really are seen or perceived as extremists. And I emphasize on extremists is like sometimes when someone says is Muslim extremist, I feel offended because if you take extremists like 1 to 10, and those people are 10, then those are extremists. Then I would be considering myself extremist, because Islam basically is encouraging me to respect you, is to deal with you with respect. Islam is encouraging me to deal with people, with my neighbors, with everyone, with a human and dignity, justice, equality, and social cohesion. This is what Islam is motivating me to do, and this is the credit I take as a Muslim when I do this. And the other dimension is beneficiaries, and we serve many beneficiaries: Muslims, Jewish, and also Christian people all over the world. So when I look to serving these communities, there are many sensitive issues where culture gets mixed with religion beliefs. There are some traditions that people believe it's a religion thing. So we as a humanitarians, we have to consider and where are the misconceptions, where are the misunderstandings, and also we should not be misinformed by what is culture or what is religion. We have to understand what is the difference between them and how to deal with them. And I can give example here. For example, in Afghanistan, when some people go to when some women cannot receive some sort of treatments because basically the specialist is a male. And this is a frequent case where we are in a really, even in Syria, even in some places where in Palestine, in Libya, it was really a major issue. That's why women is a significant members in our teams. Whenever we have a mobile medical team or something, we cannot send them without having a women specialist with them, or a nurse or a midwife. And even in Islam, if in the early Islam, most of the people who were doing the humanitarian work were women. If we look to during even the conflicts and the wars, long time ago, during the Prophet Muhammad, even the women, Nusayba, for example, she was a nurse who was during the war treating the injured people. So that's one part. And when I think about beneficiaries, also from a humanitarian perspective, is not only about humans; it's also about animals. It's even about inmates. There is many things there are many rules in Islam that protect animals, humans, and even the buildings. You cannot target buildings, which is also consistent with what we can see today in the international humanitarian law. The third dimension here is the organizations. As we deal with probably two types of organizations. There are humanitarian organizations, I mean. There are faith-based organizations, there are non-faith-based organizations. And this one is really very sensitive. We admire, we also recognize largely how faith-based organizations contributing largely in Africa, in many countries, in terms of providing health, education, basic services, poverty, fighting poverty in many places. And my colleague here, Sam, she presented really good examples of in Cox's Bazar, in even Ebola crisis, which is really significant things. The other organizations who are non-faith organizations, here it comes to service, how they will be perceived. Like, for example, maybe a Jewish based organization where they go and operate in some areas in the where there's conflict, maybe it will be perceived really badly. Same if it's Christian organization or a Muslim organization. That's something that's really sensitive, and I think that's one of the challenges that some of the organizations have been encountering in some countries in some contexts. And that's also drive some people to say, okay, what is the agenda behind this organization coming here to do all this work? Are you Muslim organizations coming to work in a Christian village? Are you coming here to convert us to Islam? Or is like these all misconceptions need to be addressed, need to be understood by those organizations when they go there, and how this affect their impartiality and also the humanitarian principles. The fourth dimension that I want to talk about is the affected countries. We know that many countries where the government, the political parties, the influential parties, all the conflict parties, they even the religious leaders play a really significant role on how your humanitarian response will be perceived. And I can give an anecdote here. In Libya, when I was working with IRC in Misrata, we actually received a request from one of the hospitals that we need this reproductive health kit, which basically include a lot of condoms. And we said, okay, that's probably they are doing a family planning. Let's just support them with this. They have a shortage, and we brought these condoms, and they were actually, they were stopped us at the port, the authorities saying, you are coming here, do you have an agenda? This is against Islam, this is whatever, these kind of misconceptions. And we couldn't answer. I said, this is based on your request. The hospital sent us this request, and we brought you the condoms as you requested. And they requested, and they said, okay, let's call the hospital. And they called the hospital. And the director of the hospital, she was really nice, dedicated doctor. She said, well, actually, we use these condoms as disposable for the probe that he used for the vaginal inspection. And they said, oh, wow, I didn't know that. So that's another issue. So we survived this issue with the authorities, but you can imagine how sometimes some religious things, and we can address this by saying, for example, the measles cases now in some areas is basically because some misconceptions about people take the vaccines or not to take the vaccines. Many similar examples of this where sometimes the religion leaders or key informants in religion, in faith in this country play a significant role in how the people react to a humanitarian response. And the last one is donors. I would go back to family planning also. Some donors, big donors actually, they prohibit us from using their money in our family planning programs. And basically, if some of them now, they have thoughts of even cutting any fund to this organization if they have implemented any similar programs of other donors or other funds. So this is also significant. And we know when you dig into why they are doing this, you see that there are some kind of faith or religion conceptions or perspective onto this. So that's basically how I look into how religion is related to humanitarian. It's a long topic, and one thing I would like to say here at the end, it's a saying from one of the Muslim scholars, Dr. Yusuf al-Qaradawi. He said that faith came to serve humanity, and by serving humanity, you serve your faith. So basically, that's not like the humanity serving the humans has to serve the religion. No, but the faith came to serve humanity, and this is the core of what we should do. Thanks.
Thank you, Osama. Our third speaker is our very own Ambrasi Edward, well-known faculty here in the Department of International Health and core faculty, or member of the Center for Humanitarian Health and Center for Global Health. She's run a number of health systems and community-based research project evaluations as PI or co-PI, providing technical support for a long list of organizations. I'll name just a few: World Bank, WHO, DFID, PAHO, Bloomberg Initiative, USAID-supported agencies, and a number of PVOs, or NGOs as we sometimes call them, including World Vision, Aga Khan Foundation, and Future Generations. And her research is focused on strengthening health systems and community-based care, especially in post-conflict settings like Afghanistan, Cambodia, Rwanda, Mozambique, Mindanao, Philippines. And among her many degrees, she has an MPH from Hopkins and a PhD from Maharaja Sayajirao University of Baroda. Ambrasi.
Thanks very much, Court, and to the Center and Paul and everyone else for organizing this very critical and important factor in not just humanitarian health, but in public health as well. I'm really delighted to be in the presence of distinguished trench workers like Sam and Osama and Dave, because they're still engaged and in the front lines. I began early in Saudi Arabia with my parents working for the Aramco health institutions, and witnessed several miracles that really puzzled me in a context that wasn't very open to any kind of evangelistic movement. And then later on, I moved to India for studies and came very closely worked with missionaries from all over the world, from the Christian Medical College in Vellore, and was witnessing on a daily basis many of their contributions in terms of faith. So I'm really happy to be sharing some of my experiences and insights, and most of all, stimulate discussion around what faith-based organizations can do and how we need to expand our scope as to how we work with them, but also learn from them, and integrate some of their perspectives and principles in how we do business in healthcare. So looking at how we trace the origins of healthcare and international humanitarian efforts, the early missionaries who accompanied the colonists in the earlier days built most of the hospitals, the churches, and schools. So it was a multi-strategy. So when you built a church, you built a hospital, and you built a school. And 40 to 60% of the healthcare in many of the African countries and in Latin America, and even some countries in Asia, are provided by these faith-based organizations. And for centuries, clergy who were endorsed or licensed by their religious order were the actual healthcare practitioners, and they still are in some of the very remote communities. In Afghanistan, we found that some of the Jesuit priests were providing the only healthcare there was, because they had absolutely no access to healthcare facilities in many of those contexts. And historically, century after Henry Durant, the founder of Red Cross, had his epiphany experience in the battlefields, religious values and Christian ideals were central to writing the UN Charter as well as the Universal Declaration of Human Rights. So it's not something that we are discovering new in public health. This has been going on for centuries. And faith-based organizations have very many distinctive competencies and competitive advantages, as we just heard, because of the decades of trust, of community empowerment. They bring in different kinds of value systems. They address equity because they work in some of the poorest communities in many countries where there's no access to healthcare. They address some of the social evils and justice. They look at reforms in terms of prisons, in terms of some of the laws and legal issues that go on in the country. And as Sam pointed out, that every individual is created equal. So addressing some of these social evils, faith-based organizations are sometimes in the forefront of providing these healthcare aspects, as well as looking at the components of social justice and social change. Sometimes secular organizations, we seem to be more paternalistic in centering our care only for relief or only for development the way we see clinical care, but we don't address the root causes of poverty, the root causes of racial or social discrimination. And this is important, though we're trying to do that, attempting to do that now. And the principles of justice and equity and valuing human life and looking at the psychosocial aspects and spiritual needs of populations that are affected by crises, and the mechanisms for religious coping are now being integrated in some of our frameworks, but we need to be actively engaged in seeing how we can meet the spiritual and psychosocial needs of the population, aside from the mental health strategies that we are integrating into our frameworks. And faith can be bridge building, because the altruism is the human impulse to help others with no expectations of a tangible reward. And it's universal. And these values of charity is present and prevalent in all major religions. But sometimes we make the greatest errors in assuming that faith-based organizations are homogeneous, and all of them have the same type of distinctive capabilities. So the typologies are important for us to know when we work and engage with faith-based organizations. Sometimes the faith is permeated in their mission, vision, values, in their staffing, in their principles. But sometimes the faith-based organizations are just humanitarian entities that just provide healthcare, and they don't have any kind of faith that is obvious. So though they claim to be faith-based organizations, when you work with them, there's no indication of or obvious signs of faith in how they do their business. And sometimes, while organizations sound secular or they are not termed as faith-based organizations, when we get to working with them, they have a very strong faith component because of the leadership and the staffing that they have. Some organizations tend to downplay the faith because of funding mechanisms, and some of them have more diverse staffing because they want to be seen as those that are accommodating different faiths and multi-religions so that they can access the various donor mechanisms for funding. And though secular NGOs are more reliant on government funds and they're restricted to donor priorities, faith-based organizations sometimes have unrestricted funding and they're not bound by legal definitions. And so there's more leverage to contribute to other aspects of development and humanitarian work. So we need to be looking more closely at how we work with faith-based organizations and come up with appropriate frameworks and mechanisms. So recognizing the role of faith is a critical prerequisite when we engage in humanitarian health. And these are just some slides from some of the experiences I've had working in different contexts, and those who've taken the QA class will recognize the slide. And this is Conflict Mindanao, where abductions and kidnappings were very commonplace. Every other day you heard bombs going off and all kinds of activities going on, especially the day that I was training. There was a bombing right in front of the training center, and they were wiping away the blood before we could begin the training sessions. But I discovered this real dream team. There was a Muslim director of the clinic, and the staff were both Christians and Muslims, and they worked so beautifully together. It was like watching a symphony or hearing a symphony. And the exit interviews with the mothers and other patients indicated their appreciativeness for the staff who, despite the threats and despite being kidnapped and despite being murdered in some cases, were very committed to providing healthcare for these patients. So when you go into these conflict contexts, sometimes you find that people of faith are the ones that are really motivated to stay and continue the work that they do. And they don't flee when crisis hits, as some of us do. They actually got the National Quality Award, and it was really exciting to find out what the motivation was for them to provide quality care amidst all these conflicts. Again, we were recently in a remote health facility. This is Tom Frieden, the former director of CDC. And here's this sole physician who was providing healthcare for about 3,500 patients every month. And once our exit interviews and assessments were over, we asked him why. And he talked about his faith and how it was important for him to serve, and that his parents built the Gurudwara there in that remote community. And he and his wife, who were OBGYNs, were serving that community. And here's a patient who is getting his blood pressure screened. And he was one of the leaders of the villages. And he said that this is the best health care he could receive because he trusts him. And regardless of whether the facility had provisions to drugs or healthcare providers or any kind of impediments in facility preparedness, he advocated to the entire village about coming and accessing healthcare from that provider. And we discovered that compassionate care for physicians, from the physician, was a critical prerequisite for them to access care. Again, another case in Rwanda. This was post-conflict. I'm sorry you can't see her as well, but this is one of the missionaries who was actually the last one to leave when the genocide occurred and the first one to return. She found that half the hospital staff had been murdered and many atrocities had taken place. But she worked and engaged with the communities. And when we were there for an evaluation, she was telling me all the wonderful things that happened, which was too incredulous to believe. And then she whirled me around and she showed me this picture of a makeshift ambulance. And this was a Tutsi woman who had an obstetrical emergency, and she was being rushed to the hospital by 4 Hutu women. And she said all the truth and reconciliation meetings that we had through the government and through other organizations couldn't build the peace-building efforts, were not as successful as working with these projects and working with our community health workers who are mostly Christian. So these anecdotes are often seen in contexts where we have post-conflict settings, and when we begin to interview these providers, aside when we complete our surveys and talk to them informally. Afghanistan was another context where we found many incredible missionaries who've been working there for many years. This is Dan Taylor, who was one of the aid workers who was killed many years ago. And when we began our work post 9/11, I was really apprehensive about going to Afghanistan. And Dr. Taylor introduced me to Dan Terry, who's been there for 34 years. He packed this bicycle with all the supplies, the medical supplies, and he was gone for 3 months into the remote hills of Afghanistan. He even treated bin Laden at one time and his staff. And his wife was the director of the Cure Hospital. And we sent many of our students there who were in Afghanistan, provided training to some of these physicians at the Cure Hospital in Afghanistan. When Dave and I were coming down the elevator, he was talking about not witnessing any reported deaths for Ebola in the child-sponsored households in Sierra Leone. And we've been looking at that data. And she was also talking about the fact that there were no maternal deaths reported after they instituted prayer in the hospital. 24-hour prayer. And they had records to show and illustrate the fact that people have begun to trust the hospital and people began to access it. And there were certain things that were happening in the hospital that they had no scientific explanation for. So these are things that sometimes we come across and we have no appropriate method to document these evidence-based practices. The Sisters of St. Mary, who were the first recipients of the Malcolm Baldrige Quality Award, and Sister Jean has come many times to the Hopkins Hospital and spoken as a keynote speaker about why they are considered one of the best health systems in the US. And one of the things that they emphasize is the term compassion, the value of compassion. So what does it mean to have compassion and love? And this is, again, Don Abedian, who I also talk about in the quality management course, who on his 80th birthday defined quality as love. It's love of knowledge, love of man, and love of God. So it seems like there are two aspects to faith-based care, which is compassion and love. So looking at the origins of compassion in healthcare, we see that it's a central tenet in most religions. And one of the papers that the World Bank published on working for God showed that altruistic providers respond to untied aid by lowering price and increasing quality. And this was a research trial that was done by the World Bank in Uganda. So there are many examples of how compassionate care is different from the kind of care that we always provide. So distinguishing compassion from altruistic intent, empathy is the ability to understand and accurately acknowledge the feelings of another. And most of us have empathy and sympathy when we think about humanitarian health. When we interview our MPH students, they always want to save the world and do something phenomenal to alleviate human suffering. But when we move on to compassion, it's something more deeper, it's psychological, there's spiritual motivators, it requires emotion and action on the part of the respondents, but most of all, it finds its basis in love, and sometimes it disadvantages oneself for the benefit of another. So this is what we often witness when we work with faith-based organizations, that there's something beyond just an altruistic intent. Coming home to our own hospital, many of us are familiar with this 10-feet edifice that stands in the rotunda. But when the hospital was established, Daniel Gilman requested the board and others who were there to bring something that would reflect a more accountable care for the people around in Baltimore, who were mostly Catholics at that time, and went to the church hospital because Johns Hopkins was not affiliated to any particular religion at that time. So during the inauguration of this, Daniel Gilman, who was our first president, talked about the ultimate physician, the great healer who wrought more wonderful cures than any surgeon or physician. One of my MPH students, classmates who was with me and worked at the Kennedy Krieger Institute, shared this book with me of Here Is My Hope, which was endorsed by the director of the hospital at that time, Ron Patterson, and the others. And they are documented evidence of faith and miracles that took place at the Hopkins Hospital. And this is another publication on testing prayer, which was also published by the Harvard Press. So there's something beyond just faith and healing and the courage and hope that faith-based institutions provide. So we need to be looking at a more expanded lens on how we look at faith and the contributions of faith, not just in terms of the ease of working with faith-based organizations because of the competencies they bring, but because of the additional values that they provide. I'm going to skip that. So in the school, we always emphasize on measurement, looking at the evidence base that we cannot manage what you cannot measure, and we quote Edwards Deming that we all need to bring data. But Archie Golden, in the Case Studies for Primary Healthcare course, always talks about the fact that not everything can be counted counts, and not everything that counts can be counted. So there's something beyond what we are doing with our frameworks that we need to be looking at in terms of what value do faith-based organizations bring in, and how can we look at some of their frameworks and integrate this into the way we address humanitarian health. Thank you very much.
Thank you, Ambrasi. Last but certainly not least, the Reverend David Robinson. And if you notice a family name connection and possibly some physical resemblance, it's true. He's my first cousin. No nepotism here. We're only buying him a free lunch and maybe some free parking. But some of this conversation we've had for many years about how does faith operate in the humanitarian space. Among other things, he is the co-author of a very recent publication, which was assigned for you in class, if you're in the class, published in the American Journal of Public Health in February 2019, called Faith and Global Health Practice in Ebola and HIV Emergencies. But he's been with World Vision for 33 years, recently retired, has been on the World Vision's Ebola response leadership team from 2014 to 2015 in Sierra Leone, has been a catalyst to adapt World Vision's so-called channels of hope for HIV/AIDS to mobilize and educate faith leaders to address Ebola at the community level. And this was, among many other things, linked to the Safe and Dignified Burials program that Sam Walthus referred to. Again, bringing faith leaders, not just Christian Islam, but local faith healers to come together and address how to properly bury a body consistent with religious practice, but also consistent with public health measures for population safety. So his work has taken him all over the world. I won't mention all the many countries, but we're very glad he's here. He's also, just because we recognize academic training, as a BA from the College of Worcester and a Master's of Divinity from Gordon Conwell Theological Seminary. Dave Robinson.
Thanks, Court. I first came to Hopkins years ago to visit his father, my uncle Court, who was a medical missionary in Korea. And we kind of joke that our DNA at a funeral a couple years ago, a boyfriend of a cousin said they were cloning in Scotland before Dolly the sheep, with the resemblance of all these, all of us white, what I thought was a heritage of a white Anglo-Saxon Protestant background. Our grandfathers, great-grandfathers, and it goes on for 4 or 5 generations, were all Presbyterian clergy. And so I guess it's in our DNA, and only about 6 months ago, I discovered that my DNA was a little more complex. That I'm actually 10% Eastern European Jewish. That just showed up in a DNA test for medical reasons. And this was hidden in my family on my mother's side 4 generations. And we're trying to find out what that is. So my roots, the faith side of my motivation, really is an Abrahamic one. And I want, recently, discovering my Jewish heritage, but also in the last 40 years, as Court mentioned, in my days in the Peace Corps, I encountered Islam. Went out to West Africa, and as a prodigal, a preacher's kid, running away from my faith, trying to look more at serving in practical ways, encountered African traditional religions and Islam, which then began to help me appreciate my own heritage, my own Christian background. And those roots, and in looking at Scripture, the parable, Jesus' parable of the Good Samaritan, or the merciful Samaritan, starts on a question, what is the greatest commandment? And a lot of you know that story. And it's basically, love your God with all your heart, with all your soul, with all your strength, and love your neighbor as yourself. This refers back to the Torah. Muslim friends, later on in the years as I was working, gave me a surah that Surah 62:5, the congregation, or al-Jum'ah, the likeness of those who were entrusted with the Torah, but who subsequently failed to obey it and implement it, are as asses or donkeys carrying heavy books. And there have been many, many times I've thought, wandering around airports, carrying books, carrying reports, carrying my Bible, am I putting this into practice? And so from these Abrahamic connections in my own family, my own work, my motivation as a follower of Jesus is to try to put into practice through humanitarian action, what does love of neighbor look like? And I want to look today at the Ebola crisis in Sierra Leone, which is where I worked, very similar to Sam's comments and the others. Faith became a problem at the beginning, as well as part of the solution towards the end. And if you've read the paper, I want to just highlight one item that the World Health Organization, CDC, other public health actors in the response began to realize that burial practices, traditional religious burial practices, were really part of the problem. And I want you to look at this slide, and I want you to kind of take it in. What do you see? And I wanted to focus on the word, this is from a well-known psalm, the 23rd Psalm. Even though I walk through the darkest valley or the shadows of death, I fear no evil, for thou art with me. Sierra Leone is a very religious society. Over 95% of the people tallied in the Pew surveys on religion in the world, 95% of Sierra Leoneans say that their faith is the most important value and source of their values for their lives. If you go through and look at the statistics, somewhere between 80 and 80% or more identify themselves as Muslims. 15 maybe % identify themselves as Christians. And as a Sierra Leonean said, yeah, but we're all African traditional believers. So the mixture of culture and religion in Sierra Leone was a huge factor. And as people in PPEs walked in to take care, removing a sick, infected man from his house, this instilled incredible fear. Fear is what Ebola was. It's invisible. Fear about why are these strange kind of like space suit men, primarily men, most of the burial workers and most of the health workers who were actually going out into the homes were men. So later on, the inclusion of women was really important in helping families cope with the fear that came in. Fear, was Ebola real? What was spreading it? So fear was a driver, a huge driver. A study that was done by CRS and Focus, a local Sierra Leonean NGO, showed that 37% of the transmission rates were coming after burials and after the traditional washing of corpses. And so WHO held a meeting in Geneva in October of 14. This is 7 months into the infection actually being declared. So infection rates were spiking, and they were trying to get to what is really spreading it. WHO called together and said, look, it's not working. The protocol they had at the time, which we were asked to help to implement, was called Dead Body Management Protocol. How many of you have organized a family funeral? You don't talk about it in the family as dead body management. It is not at all a way to address it. And in a society where 95% of the people look at their spirituality as the #1 value, having people come in looking like spacemen, spraying chlorine, burning down your house, basically. People began to hide bodies. People did not want to report the infections. People did not believe what was happening was really a disease. So WHO calls to ask the World Council of Churches to convene a meeting to address this issue of dead body management and bring it into what families in Sierra Leone were expecting, not just Sierra Leone, but Liberia and Guinea, Mali, other countries. The International Federation of Red Cross, Red Crescent Societies, Caritas, the Catholics, Islamic Relief, and World Vision began to work, and in one day came up with a safe and dignified burial protocol, which basically shifted the dead body management to then making it a religious and spiritual ritual that families could then be involved in, inviting the imam, inviting even the traditional healers, inviting their priest, inviting their pastor to come. And to stop the body washing that was part of Sierra Leonean and West African tradition. World Vision, I was assigned to go in, having had almost 30 years working in mixed faith communities. We began to work with every faith group we could. And here is Bishop John Yambosu, who greeted me in his office. He was part of the interreligious task force on addressing Ebola in the country, along with Imam Khone. And this is how he greeted me. It's basically avoid body contact was really what was going on. You had to wash your hands with chlorine. And prayer, prevention, and care was their approach, the Methodist Church approach. We began to work with the local councils of imams and pastors. This is El Haji Imam Koker and Pastor Peter Kanua down in Bo. And the local interreligious councils began to then train faith leaders. And I went to Bo, and we worked with, these are basically pastors, priests, and imams, working on implementing the new safe and dignified burial protocol. DFID, the UK aid, gave World Vision, CRS, and CAFOD, a British Catholic aid agency, over 14 million pounds to implement burial, a whole nationwide burial approach, calling a toll-free number and ensuring 24-hour response, dignified burial opportunities where every family would say, who's your local pastor, who's your local imam, who's your local traditional healer, how do you want your religious faith to be part of this? So protecting the living and honoring the dead, basically merging public health biomedical information and faith-based burial information together. And this is the report at the end on the barriers and the enablers of community acceptance. Sam earlier talked about faith leaders as trusted messengers in Liberia. The trust of information going to families, and burial rates increased, the hoarding of bodies stopped, and infection rates began to go down. Here is a pastor, local pastor, with the burial team about ready to remove the body from the community, reading a psalm, reading scripture. One item here, which I want to just point out here. The black body bags became a huge barrier. In traditional burials for Muslims and others, a white shroud eventually was then offered and then given by the family, and white shrouds were added. But the cultural, traditional, and faith-based issues and barriers had to be addressed. And each one of the other of my colleagues here have mentioned that. Some of the painful lessons, this was listed in an article in the Post, which I won't read through, but several of these talk about respect of culture and religion, which at the very beginning, in the rush to defeat Ebola, were forgotten and eventually added. Brazy mentioned at the end of this project, back to the DFID grant that was given to us, they had asked us to take the faith leader component that we had written into the grant out. So they wouldn't actually, in the evaluation, pay for the impact of faith leaders because it was not a critical objective in the grant contract. So World Vision came up with some money, came to Hopkins, and this report, a team from Hopkins went out, and in the summary, was basically to look at the effectiveness of community-based approaches on the prevention and management in the Bow District, where I had been. One of the unexpected findings of this was out of 59,000 sponsored children, which basically meant about 200,000 family members covered in our programs in 25 districts, that not one of those children was a fatality, nor their families. And the study began to show that trust and the presence of trusted volunteers through faith-based networks and other networks, that trust really was a factor. And this is one of our, back to data, back to evidence of faith playing a critical role in Sierra Leone during that crisis. I want to point out a book, if you're interested in reading further in this, that got me really introduced to it, is The Ambivalence of the Sacred, which was really a study looking at religion, violence, and reconciliation by Scott Appleby, which became a text for me when I was working in the Balkans, in Bosnia, working with Orthodox Christians and Muslims and Catholics. Thanks very much.
So before we get to Q&A, please join me just thanking all of our presenters for just their keen insights into how faith operates and functions well together with other faiths and sometimes not so well, but hopefully offers some instruction and guidance toward the future. So in the time we have left, I think we have about 6 or 7 minutes, if my watch is correct. The floor is open. The microphones are here. We can hand them around if you'd like to just speak sitting down or as you wish. Yes, in the back, Shata.
Thank you very much. I'm going to ask a question which you probably asked often, so I apologize in advance. But
despite the fact that local faith groups form the bulk of local capacity in many areas of the world, there is a reticence or perhaps even skepticism on the part of many international organizations to engage with faith-based groups out of a belief that that the way they operate is inherently at odds with normative humanitarian principles of neutrality, impartiality, independence. So can you speak to the validity of these concerns and how you navigate those tensions as you work?
You can decide who wants to pick that up first. I'll let you all figure that out. Anyone? Sam?
Great question. I think for us, AJWS, it's not only the faith-based groups that we're supporting, but it's really the locally based response as a whole. And often those groups that we're supporting are those that are often mostly ignored by the mainstream responders. So it's about elevating those voices as well and getting them a seat at the table when there are the cluster meetings or when there are there are avenues and mechanisms that they can access themselves. Sometimes they don't know because it's in English only. So I wouldn't say it's just the faith-based groups. I would expand it to say really the local grassroots groups that are often ignored by the response. And so our job is to advocate and partner with them so that we can elevate their voice and get them a seat at the table.
Yeah, it's a good question. It's a very practical issue for NGOs working with local faith leaders. One of the quips, one of the jokes in Sierra Leone was also the issue between the local communities and the central government. And if a local council of imams doesn't have a political friend in the capital, they're not going to be introduced to a donor or to other players. That's one of the factors we encountered in Sierra Leone. A Sierra Leonean friend told me, we in the bush, we wash our hands, but you in the capital eat. And, washing hands was the symbol of being ready to get involved in the Ebola response. There are issues, and as the ambivalence of the sacred talks about this, religion is a double-edged sword, and it can be used to harm and alienate and divide communities, and often it does. and yet it can also unite. And so finding the way to build the bridges, the Interreligious Council of Sierra Leone, in its post-Ebola evaluation, said it had not done a good job of inclusion. And they didn't work well with the Pentecostals. The Pentecostals did not want to work with the UN, did not want to work well with Muslims. So there were religious divides that had to be even almost bypassed. So you've raised an issue that is a thorny one, and it's going to be there, but I think to do a good public health response, it needs to be tackled straight on.
Do we have other hands here?
How can you probably advise or what you think about it? How can you encourage and promote women leadership in local group, taking in especially faith that women are supposed to be receiver and not even speak up, and also taking into account of the significant number of women in public health field?
I don't want to single out the women on the panel, but why don't we look to them first?
I think working with Christian communities, it's easier to refer them to the scriptures where Jesus, in Christ there's no male nor female, and everybody's equal. And when we work in Afghanistan and places where there's a different kind of cultural practice, we still work with the imams. So you work with the religious leaders and work independently with men and independently with women. Sometimes the disfavor we do is excluding women and calling for women's empowerment and not including the men. So when Dr. Taylor and all of us were working in Afghanistan for women's empowerment, it didn't go well with the policy leaders. But when we called it family empowerment, family health, so we need to work with all groups to improve, educate, and not just tease out the vulnerable. Because advocacy, to some extent, for justice is never neutral. You will be treading upon some existing norms and cultures. So we need to work very slowly, humbly, learning and respecting the existing norms and values and working with different stakeholders. And sometimes it takes a long time, but it has happened. Women have come forth in leadership even in these cultures.
I'll add one thing with the caveat that I'm also incredibly fortunate that we work for a human rights organization that takes a lot of risks. And when you go into communities and you have the trust of those communities, there's always one woman or one girl that says, I don't want my girl to be married off when she's 9, or I don't want to live in this patriarchal society anymore. And that's the person you support. And that's the voice you help elevate. And that's what we're able to do. And often that person or that small group is just an emerging social movement. And it's really important to be able to support those social movements, registered or not, to follow the agenda that they've set out for themselves and not to impose your own. And also not to fall in the trap of making them NGOs, because then they are part of a system that perhaps is harder to then break through, and really helping support the movement grow and change.
And if I may take just a brief chair's prerogative or moderator's prerogative, I think it's fair to say all of the religions represented here, including my own, are deeply rooted in patriarchal societies and structures. Institutionally, I don't think that one needs to look to scripture for that per se, but that's where it comes from. And it's a whole nother conversation to talk about how within a given faith, more sort of, if you will, progressive movements versus more conservative movements are also in conflict and clashing. So movements to ordain female priests, movements to have female rabbis is recognized in Reformed tradition, but not in the Orthodox. Same with Christianity, same with Islam. So we should be careful not to impose a sort of monolithic view on any particular faith, and recognize that among many challenges that all of these faiths are dealing with is what is the role of women. It has not been well acknowledged or respected over the many centuries. Let's just acknowledge that. And we can also hope that that is changing from the ground up. or top down, or in between. So we had another hand here, and I think maybe try to do two more if we can. I don't know, we're a little over time, but if you can stay and don't have classes, we can continue until they kick us out or they shut down the video camera.
Well, thank you so much for coming here again. A theme that's kind of come up in all of your statements and talks was this idea of trust, especially as we consider institutions like Hopkins, international NGOs, sort of becoming increasingly secularized. One of the obstacles I can see to building trust with religious communities and religious leaders is just a lack of understanding, a lack of religious literacy. So what can secular institutions do, or non-believers within these institutions and organizations do to promote religious literacy to help build that trust in the communities that we work with that might look very different from our home communities?
Do more things like this. I think the data, getting the data, is one of the reasons a number of us, after the Ebola response and other things, is document what happened. One of the big issues in the DRC right now, Eastern DRC, I've got an email from an anthropologist in Kinshasa saying they think this is all medical. This is the 10th outbreak in the DRC in the last 40 years, and even internally in the government in DRC, there's some resistance to engaging the faith community. And there are lots of reasons for that. But one is the documentation. A lot of us in faith-based organizations have been doing this for decades, are saying we've got to tell the story, we've got to document it. So that's part of the rationale behind the article that I got involved in writing. But I would say also take the risk, as Hopkins did, in sending out a research team to Sierra Leone to take a look at what's the evidence base. And that funding of that is a challenge. Getting a donor to include that as part of the social dynamic and a social foundation for good, inclusive public health has not really been funded very well. So I would say we got to address the donors as well.
Others? Yeah. Did you want to answer? Okay. I think we have time for one more. Do you have a hand up back there? Floor is open. No, don't be shy. Well, try one.
Okay. So thank you all. That was so interesting. One thing I'm wondering about is in places, a lot of the places that you all work, there's been this history of colonialism and then missionaries that came with that. And I'm just sort of wondering about, you were just talking about trust, but then sort of the trust that, and you touched on this, how people might expect that you're coming with this agenda of proselytizing. And I'm just wondering if you could speak to how you navigate that in some of these places with these histories.
Yeah, I think one of the important things when we part of my job now as to establish country entries for SAMs beyond the Syrian crisis. So we are now thinking to reinitiate our program in Bangladesh, Yemen, and other countries. But one important thing, one different context that we are going to is Tijuana, Mexico, for example. This is a kind of surprise to the board when we say, we're going to Tijuana, what do you think? And so, why are you going to Tijuana? But one important thing, before we go to any new context, a new country, we need to be avoiding any misinformation. So you do your research and you do your homework of knowing everything about the social cohesion, the social structure, the religion structure, everything in this kind of context, new context that you go to, and the history, why this kind of issues persist, the inequalities, the injustice, and who are those people who are there, and you kind of navigate all of this and you know, for example, that there are things that religion related or faith related that you should avoid doing, or you should avoid, you maybe encourage something, maybe some donors would be interested to work in this area because they are faith-based donors, they might be interested to serve such kind of group. So all this kind of things like you navigate before you send any team there, and do not like just react by sending a team to do anything without doing your homework and research.
Anyone else? Maybe just final comments, if we may, because I think we need to wrap this up. Just last words from anybody. You don't have to, but just this is your chance.
Firstly, thank you. And secondly, just remembering the grassroots and the locally based organizations, first and foremost, whether they're faith-based or not, the importance of really supporting locally led groups to realize the vision that they have for themselves and their communities. Thank you so much.
Again, thanks very much for hosting us. I've learned a lot from all of my colleagues here. I'd say continue to read and invest and document this field. It needs work. In answer to the question about women, one of the last remarks in Sierra Leone in Bo in a post-Ebola conference, the woman, a Muslim woman, stood up, who was the vice principal of the local high school, said that the Ebola crisis had really convinced her that women's literacy and ending child marriage was her life goal. That the women were the primary victims of the Ebola crisis. They were the caregivers, they were the nurses, it was mainly women who paid the price, not just but also in Ebola still spreading due to sexual contact after Ebola had stopped. The virus reservoirs remain in the testicles of men. And so women really paid the price in illiteracy, and the lack of ability to finish school became a passion that she spoke about in the last meetings that we were in Bo. So you're onto something. Go for it.
Well, thanks again for your insights, because I think it's really important for us to consider integrating these aspects into our research, into our framework, and having the humility to learn from the communities and from the people and their perspectives, even as we have something to offer them.
Okay, and on that note, we will say thank you again for those who've been listening in via web, those of you here in the audience, and those of you here on the panel. Thank you all.